Hello, everybody all over the world. I will share with you my lecture now, and then we start to interact virtually to each other. So I'm back again with slides, this time lucky the ones which came later on. So again, I would like to emphasize on the reality that we need to focus on aesthetics independently if we work freehand or digital. Since the digital revolution came into our offices and the technologies are so fast that we need fast and reliable studies to offer parameters, coordinates, and the way to implement those parameters in a digital workflow. That's why my message today would be the science and clinics, and my mission to offer you the science and clinics on full arch rehabilitations, where we are in this digital workflow, and which are the parameters which makes our treatment predictable and reliable in the whole procedure. Now, in the latest statistics, which I did on my own implants, in an immediate placement and immediate loading procedures over 25 years, and are only not all the cases implementing in the statistics, but the ones which we evaluated led to a success rate of 97%, 97.9%, which is quite high. And this statistics is concerning not only my study, but also studies have offered the same number from De Guidi, Piattelli, Karmish, Deborah Schwartz, and so on. Now, in all these cases, we tried to offer the best aesthetics on implants and on natural teeth, but also in teeth and implants adjacently. And we offer also parameters of peri-implant aesthetics and implementation in the full arch restorations. So there is plenty of literature out there concerning the freehand implant placement in daily office. So all this compromise, atrophic or destroyed anatomic situations were rehabilitated in a freehand implant placement with implants, adjacent implants, but also teeth and implants. And it succeeded in a good aesthetic situation. Now, all these results were reached and got to by a good planning, by using good implant designs in a following parameters of implant positions, principles of successful bone grafting, soft tissue dimensions and grafting of the soft tissue, which we'll address a little bit later, a surgical philosophy, prosthetic design, digital workflow, and parameters of function and maintenance, which we will address later on. So all these parameters which we used in a freehand restoration are also valuable and to be applied in a digital workflow. Nevertheless, since we aim to a procedure which need to be more and more minimally invasive, some of the parameters will be changed and more parameters will be coming to play in order to do the digital workflow in full arch rehabilitation predictable. So we have three ways of doing the implants today: freehand navigation, a static navigation, led and guided by surgical templates, or dynamic navigation or made by stereoscopic camera. So we will go through the navigation, static and dynamic, and we'll see if this treatment is minimally invasive, is more minimally invasive than the freehand, is offering a higher precision of the treatment, is giving us a better aesthetic and functional outcome, a higher predictability, and a reduced time, which we all hope and aim, because this is the reason why we step into the digital revolution and the digital technologies, and not because they are really cool. They are, but it's not the reason. Now, we placed together with a team from Frankfurt University, and also Uli Hauschild, who is also a board member in the Digital Dentistry Society and a great technician, which was the team where we did all these cases, doing a retrospective study over all these full arch restorations in immediate loading procedure. We saw that, yes, the success rate is even higher than in freehand. That means it is more predictable. So let's go through this workflow and start with a scan, plan, make, done, staged procedure. So we reflect our treatment in 4 chapters. Scan, which is the acquiring all the digital data. Plan, that means the digital planning of the guide, of the restoration. Make, which is the manufacturing of all the parts which are necessary to the surgery. And done, that means the surgery itself. So the digital workflow starts with the digital acquirements of all the data through all kind of different softwares which we implement, starting with a photography, with a video of the patient, with a face scanning, intraoral scanning or lab scanning, with an occlusal analysis of the patient, digital movement registration through a certain technology, which I will show you later on, and also a DICOM data acquirement. The digital photography is not used only for lectures, is used definitely for the technician. This is the first tool which gives him an impression and also some parameters for him to do a 2D visualization of the future smile, which is the first step of the planning. There are different softwares to plan this. We will see it later on. Nevertheless, these pictures are mandatory. The DICOM data is mandatory. We, of course, work 3D and not 2D. Of course, you have the possibility to plan very roughly your cases in a 2D picture. But since we work 3D, we have to do the diagnosis and the planning 3D if it's any possibility. And in the choice of those technologies, we need to take care about some criteria. To take a technology which offers image accuracy, to offer multiple fields of view, to have low dose capabilities, but is also the hope, and we see the technology coming, which is offering a 3D picture with X-ray dose of a 2D picture. So this is coming. In the future, we will really work only 3D. We need a secure patient positioning because the first origin of distortions and mismatches and inaccuracies is the bad positioning of the patient or the movement of the patient. We need to implement more technology in one, and so on, and reducing artifacts. The intraoral scanner. Well, we know that the intraoral scanner is a nice technology which is offering a 3D picture of the teeth, which the technology has to have a high trueness, high precision, and there we have studies about it. But all the intraoral scanners have the same issues. I mean, generally, they offer a full arch. We cannot do a full arch scanning for a restoration with the highest accuracy. But we can do a scanning of the one implant restoration or multiple implant restoration with a good predictability and a high accuracy. but accuracy in a full arch reconstruction is not necessarily the most satisfying. The second thing is that the intraoral scanner is offering you not necessarily the accuracy of the preparation margins or of the margin of the restoration when you have a blood situation and so on. Nevertheless, I will show you later on some artificial intelligence properties which can offer us the possibility to go really digital. So we really move forward on that. The function was not possible to register the function before in a digital way and to implement it in the digital workflow. Now we can. We have technologies out there which are registering the movement of the jaw, which we can implement it in the digital workflow, and we take this movement in the whole process of the planning and of the planning of the implants and of the planning of the reconstruction. So we have all these parameters for the provisional and also for the final reconstruction. A sensor-based registration of the occlusion. Now, this is a technology which we need not only on implants, also in natural teeth, because the blue paper, which we used before, is really last year. We need a much more detailed and much more precise control and adjustment of the occlusion, since we know that the implant complication is a peri-implantitis, which is a bone loss plus infection. So in order to avoid the bone loss, we have to give the patient the best occlusion possible in order to not to have all the complication connected to that. And this is a sensor-based technology which we use in the full arch reconstructions also, which I will show you later on. Now let's go to the second chapter, which is a plan of the work. Plan means the visualization 2D and 3D of the future smile, of the future patient. And here we have plenty of softwares and technologies, beginning with a kind of keynote representation of the teeth, of the golden proportions, to apps which are able to give you automatically the future smile, but also an artificial intelligence-based technology, which is giving in movement, like the Snapchat for teeth, the new proportions of the teeth, new color of the teeth, a visualization of the future smile. Now, all these new parameters which we establish and which we visualize can be, of course, implemented in the planning procedure of the implants and of the future reconstructions provisionally and finally. Plan means also the planning of the guide in a certain way, which we will discuss later on. And the planning means planning of the provisional, but also the final reconstruction. Now here, and this is the future and present technology, which is behind all the digital technologies, is the artificial intelligence, which is able today to trace the nerve in the cone beam CT and in the planning software. And also working on, we're working also on a software which is able to place the implant automatically in the right position without all the movements and all the manual issues which we have today. Okay, let's step to the make stage. The make stage is the manufacturing through printing and milling procedures of the model, of the provisional, of the guide, and later on of the final two. Well, printing is the future milling, as you will see at the end of the lecture. Printing is able to give you the details of a surface and of a profile much better than a milling procedure. And the issue is that the higher the precision and the accuracy of the printer, the higher the precision of your procedure, because the guide is much more precise. The more precise is the printing procedure. So this is one or another study which we did in cooperation with Francesco Mangano, Matteo Bonaccina in the Digital Society, and it is published in the BMC Oral Health. It's a study based on where we had models printed in comparison with each other with the different printers. And we did linear measurements and amplitude measurements, where we had some results. Now, the different results of different printers is depending on the technology of the printer. Some of them are based on light, some of them are based on mirroring. And of course, diameter measurements had also different values. So because the second reason why the results are different is because the materials of printing are also different. Another conclusion of the study was that even if most of the models printed offered acceptable accuracies with slight differences to each other in different directions, 3D directions, we saw that the trueness after printing was low. That means that the 3D printed models had some dimensional contractions over time. So this was the second conclusion. Now, after we printed all these items for the surgery, we go to the surgery of the full arch reconstruction and we do it using all this items printed. Of course, the all-around accuracy in the guided surgery is also a subject which needs a lot of studies, and we do a lot of multi-center prospective studies on that and trying to find which is the best workflow with the best accuracy which we can receive. Now let's go through some aesthetic parameters and aesthetic cases from small to big, and I would like to offer you some parameters of aesthetics which you need to implement in a digital workflow. This is a young lady which had an accident and lost one of the frontal teeth. Now, the bony situation was quite okay for the implant placement, but the soft tissue not. So we reestablished the soft tissue aspect and thickness through a connective tissue graft from the palate. And after we had this rehabilitated soft tissue situation, we made digital planning of the implant. And at the end of the day, by the prosthetic restoration, we had the amount of bone and the soft tissue, which is essential to a good final aesthetic in a right shape, form, and emergence profile. Now, what is here important is the dimensions, and this is what I wanted to emphasize on, of the soft tissue around an implant, which has to be in consensus 3 millimeter tissue thickness, 3 millimeter tissue height, and 3 millimeter of keratinized tissue around implants. Doesn't matter if are two adjacent implants or implant and tooth. Now, this is those are parameters which are completely different from a very traditional implant and peri-implantary environment. Today, we have platform switching design of the implants, which offer less bone loss than a conventional design. We have only 0.6 bone loss instead of 1.46. Then we have much more amount of supracrestal fibers because we didn't lose the bone, and because we took care of the implementation of the soft tissue thickness and height. Now, on the top of it, and if you look at the right picture and animation, we have we designed the emergence profile in a S-form shape, which is a concave convex profile. And we respect the physiologic distance for a contact point between two crowns in order to be able to design and stretch, let's say, the amount of the soft tissue gained into that triangle between the crowns. So those are prosthetic details and designing details which contribute to a longer papilla and to a more coronal papilla that we had in the past. And those are details which has to be respected in those constructions, even if it's a one tooth or a two implant, adjacent implant reconstruction. So we know now that the S-shaped concavity of the transmucosal portion offers a better connective tissue barrier. And this is the design of the abutments which we use in single teeth, but as you will see, also in a full arch rehabilitation. So this is the aspect of the reconstruction as a whole. Stefano Inglese did this rehabilitation, and the patient is really happy. And this is what actually every patient deserves, even on implants and on natural too. This young lady has missing laterals, and this was an interdisciplinary case where my orthodontist, Nuno Sousa Diaz from Portugal, as you see, we work very internationally, opened the gap for my implants. You know that when you're missing laterals, you really miss bone in that region. And we had to implement the bony situation. But before we started with that, we implemented the aesthetic, and we visualized 2D and afterwards 3D, the smile, realizing that we need to do a little crown lengthening and also some non-minimal invasive veneers on the other teeth in order to give the patient a pleasant and a pleasing smile. In the bone grafting, we try to go to very minimally invasive procedures. Either we take an incision which doesn't give any scars and doesn't give any recessions. So we rather look for a non-invasive, a minimally invasive way of incision, which goes through the sulcus, but avoiding the cut of the papilla and avoiding vertical releasing incisions in order not to have scars and not to have recessions. So therefore, we have then a very pleasing situation of the soft tissue. So as implantologists, you can see, and even digital or not, we have to be a really good surgeon for the bone and a good really periodontist for the soft tissue. And on the top of it, to be a good digital dentist, right? So, and prosthodontist. So therefore, you can see the visualization of the missing laterals and the planning of the implant. Now we realize, and this is one of the old cases where we place the implants after some parameters, meaning, and I'll show you in a minute, meaning 4 millimeters in the depth and 4 millimeters from the buccal plate. I will go a little bit back to show you the amount of bone that we gained with the bone grafting. And then we go to the surgery, very minimally invasive, and very precise. And you can see the parameters of planning of the implants, which are 4 millimeters. You see the yellow line, 4 millimeters from the most buccal contour, around 4 millimeters. So added the soft tissue thickness and the bone thickness together were 4 millimeters. And the total distance in the depth of the insertion, also 4 millimeters. We treated at the uncovery of the implants, the site also with PRF in order to give a better healing. And then we went to the CAD/CAM rehabilitations on all the teeth, which we thought that it will give a better smile. And then with a minimally invasive preparation, we had the final result. Now, after 2 years, we had the permission of the patient to do, again, a cone beam CT and a scan. And overlapping those two, matching the two, we saw that in the regions, because we had that around 4 millimeter algorithm for the placing of the implant in the depth and in the buccal aspect, we have a constant, we didn't have any volume loss. And the aesthetic situation, as you saw before, was constant. So that was the beginning point where we said, yes, we have to plan to respect this algorithm in the full arch rehabilitation also and evaluate the aesthetic result. And this is the subject of an ongoing study, which will be published in a couple of weeks. So in full arch navigation, we have the same steps from the scanning, planning, make, and done in the steps which I showed you before. Now, again, this is the subject, the aesthetic parameters for a full arch reconstructions are the subject of that prospective study, which we do right now. And I will offer you the preliminary results in a couple of minutes. I hope I will be on time. Now, the FP1 situation, the Frick's prosthesis 1 situation, is the situation where we don't necessarily need to open the flap. and we have to maintain the structure existing. So this is a situation where we have, and we have to find, we have to find a solution to respect and to give to have these algorithms of the planning, the 4 millimeters, to have a certain thickness of the soft tissue, the certain bone thickness around the implants. So we have to find methods of grafting which are really minimally invasive in addition to the digital planning. Now, this case, for example, is not even a very old. We started with the scanning, with acquiring of all the digital data, with the planning, that means planning digital in the same technology of the 3D smile. Yeah. We plan also the implants one by one by an immediate placement and immediate loading procedure. We implement the digital movements of the patient and the facial scan into the same technology. So this is the situation, which the starting situation. Of course, we need to open the occlusal vertical dimension, as you can see there. And this is something that you can do it in the software of the movement of the mandibular movements registration. We do in the planning phase also the planning of the implants, the planning of the guide, and a very good rule is to keep 2 or 3 teeth for the stabilization of the guide. We know from very reliable statistics and studies that a tooth-supported guide is much more precise than a soft tissue supported guide. That is why additionally, or without any pins, we take some teeth to support the guide, independently if we work with pins or not. And then we extract those teeth for the restoration, of course. Or we use 2 guides, as I will show you in the cases afterwards. So we plan the guide digitally, and then we go to make them, to print them in a very reliable and very stable construction, right? This is a sleeve-guided procedure. The provisional will be also manufactured on the hand of the planning, and you can see that in full arch rehabilitation, we need some reliable ways of keeping the occlusal plane and the occlusion generally, and this is in this case of an plane and plate for the palate, and then we go for the surgery, which is actually then really a very well organized procedure where we have a certain sequence of the drillings, and everything is working very planned. Before the surgery, we always have a session with my assistant and with a planner too, in order to discuss all the issues which can occur, and everybody knows what's going to happen. And that is why the surgical procedure is minimized time-wise to the most. So this is the aspect of the implant placement with the guide and with the mountings, the set implants after the planning, which we did, respecting the aesthetic parameters of depth and buccal parameters, which we discussed before, around 4 millimeters. And this is the aspect of the implants plan. In the situations where we don't, and the sites where we don't place implants or we extract tooth, we always cover and take care of the thickness of the tissue by matrices or by PRF. I will talk about that a little later. And we place a provisional in the same session. So the patient goes with this situation, which is completely different with how she came, right? Now, another lady wants also fixed teeth in the same session in their upper jaw. So in this case, for example, we work with 2 guides. The first guide will be placed on the residual teeth, and then we extract those teeth and we place the implants in the frontal area. So the planning will be done the way you saw before, based on the 3D visualization. And as you can see here, we have 2 guides, one on the left side placed on the teeth, and then we extract the teeth and we mount the second guide on the already placed implants. You can see that you can do internal sinus elevation in the same session, or densa drills, and so on. So you can do all the procedures accordingly. then you see the positioning of the implants, and in all dimensions. The provisional was made in advance in the phase of planning and manufacturing, and the final will be done by a tooth-by-tooth reconstructions, the CAD-CAM, the way I showed you before, a screw-retained reconstructions. And we try also in the planning to do a screw-retained reconstruction. Is not always possible. And this is the patient with the final result. Superposing the planning with the final result after 2 years, we realized that the situation is stable if we respect the 4.2 millimeters or around 4 millimeters algorithm. The same with Susanna. Susanna had short teeth. We needed to open the bite. We did at that time, this is also older case, and wax up, not a digital one, which we scanned with a lab scan, did the planning after the proportions, planned the guide, and manufactured the provisional, this time with a metal frame because the patient had really short teeth. So we took care of that, the rules of immediate loading. Went to the surgery, and as you can see, sometimes we need to do grafting in the same session. Not always is a flapless surgery, and I will show you also other types of guides which we use for and which offers the possibility of grafting in the same session. So you see the situation after the surgery, and this is how the patient goes home. So it's really a very nice procedure. Now, for sure, you read the literature about triple guide and scalloped guide. So the thing is to predict and to give the patients immediately the most accurate situation. So this concept used also in FP3 situation, we can use it also in the FP1 situation when we don't need a scalloping of the bone, but we try to give the most accurate occlusal position as possible in a triple guide. One guide is supported by pins, and all the other surgical guides are connected with this first guide. Now, the thing is, we don't really know exactly if, we are about to evaluate the results of this kind of stacked guides to see the accuracy of the results at the end of the story, because we are not sure that the accuracy is higher in this situation as in the other. So this is also a subject, and it is an ongoing study. And this is the provisional, which is the third thing which is stacked on the stabilizing guide. So that is how we make sure that the occlusal situation is the one we plan and not another. Now, Asimine has periodontal situation, a disastrous periodontal situation, despite of her age, of her young age. So no matter what we tried to do, and we made a periodontal treatment, after 1 year of treatment, the teeth were still infected and still mobile, and the residual bone height in some of the regions, as you can see, is less than 8 millimeters. So this is the situation, and this is actually the parameter which we need to, and a consensus which should be between an implantologist and the periodontist to make a consensus. Now we extract the teeth. After 1 year of treatment, we have infection, mobility of the teeth, and the residual bone height is less than 8 millimeters. We extract the tooth and place an implant. Then otherwise, we need much more invasive procedures to give this young patient a decent restoration. So the patient will get in the upper jaw through immediate placement, immediate loading, implant-supported restoration. In the lower jaw, though, there are 7 teeth which can be saved, periodontally treated and saved with a long-term prognosis. So we did, with the help of Uli Hauschild, again, this is one of the cases presented also in the study, on scanning of his wax-up. We also talk with the patient about the treatment which she needs to follow, and this is as I said, complete supported implant restoration. In the upper jaw, we will have single teeth. In the lateral, we will have 2 bridges, and in the lower jaw, we leave 7 teeth because they are to be saved. Now, this is the moment. The planning moment is the moment where we decide actually how the surgery will gonna occur and how the restoration, the provisional one and the final one, will look like. So that is why we need to respect the algorithm of aesthetic planning, the soft tissue thickness dimensions, if the implant design also, because we need to have a good implant design for a good stability of the case. And also we will plan a guide. How do we do the sinus elevation? Because it's an open one this time, and so on. In this case, we will also leave 2 teeth in order to support the guide. So those are the algorithms which in the moment of planning, we need to decide. We need to have, so that is why in the digital workflow, the planning procedure is the most important. Yeah, we plan design, position, number, grafting procedures. How do we do the navigation, a surgical guide type, and what kind of reconstruction we have in the provisional or also in the final. So we take care that we have the bone amount or the soft tissue amount or the added value of 4 millimeters. We know that we need optimum of 2 millimeters bone around implants inside or outside the sockets, and we have to have this 3 millimeters of soft tissue, or as a conclusion of what we talked before, a 4 millimeter added dimension. The height of the soft tissue is important because especially in adjacent implant situations, because it's the fuel, it's the volume that we need to be designed between 2 implants or implants and teeth. Also, we thought that all construction should be palatally screwed, but we know now from Joseph Kahn that 80% of the situations are anatomic situations where they don't allow a palatal screw. They have an buccal screw. So we need systems which either offer us a multi-unit abutment for the single tooth or a tilted canal or other procedures in order to go palatally. Nevertheless, we can have also parameters of cementing, which we will talk about later on, regarding the design of the abutment and the height of the soft tissue. Nevertheless, the dimension and the algorithm is that we need to have a 4 millimeter depth of the insertion. And this parameter is respected in the depth of the insertion, but also is the same, is the buccal distance from the collar of the implant to the most buccal contour of the soft tissue. Both are 4 millimeter added value, soft tissue parameter, soft tissue height versus thickness, plus bone height or thickness. So another step is the provisional, which is made in advance. So we go to the surgery and it's a flapless surgery. As you saw, we left the first premolar as a support of the guide. Then we extract the premolar and the second premolar, and then we extract the premolar and do the complete implant supportive restoration. So this is the aspect of the implants, and you can see that the precision of the placement of the implants is much higher than the freehand, even if we are really skilled. And we know now that the more precise the positioning of the implant, the more precise is the end result, and the more stable is the end result at the end of the day on the long run. So soft tissue dimensions are here present. So the depth of the insertion of the implant is respected, so we don't need additional procedures of grafting. This is the provisional of Azamine, which in the next day she comes, she's a little bit swollen from the sinus elevation, but nevertheless, she's very satisfied. And now we check the occlusion again. We adjust the occlusion of the provisional restoration because sensor-based, because we need a balanced occlusion, is an immediate loading, so we need to respect the balanced occlusion, a harmonious occlusion, and also the soft food for the time of osseointegration. Now, after the time of osseointegration, 4 to 6 months or 3 months, depending on your philosophy, we think about eventually to do the final impression. Now, since the final impression is digital, is not as precise as we would like to, we go for an open tray analog impression over all the implants based on multi-unit over the multi-unit abutments. And the second impression would be over the provisional. Matching the two, this would be the fuel, this would be the base for modeling the final abutments, which has, as I told you before, an S-shaped concavity. Now we use the features of the technologies, of the planning technologies, to place and trace the margin of the abutment by recognizing and being able to measure the soft tissue thickness. So we can do that. We did a study on the intraoral scanner technologies with Francesco Mangano and Jafar Mouhi, which was published shortly in the BMC Oral Health, highlighting the properties or the features of the artificial intelligence in fixed reconstruction. So we realized that when we do an scanning of the provisional abutment over an implant, then this data will be saved as an STL format in the memory of this technology. Then when we go for the scanning of the position of the hybrid abutment after healing, what the computer does based on artificial intelligence is able to recall this STL data from the right patient, from the right tooth, and matching it with a highlighted zone of our new scanning. So this is artificial intelligence. And also it's possible to trace the line or recognize the line of the abutment independent of the position of the gingiva. So this is just a small hint to what artificial intelligence is able to do, and it's much more coming in the future. So therefore, the dental technician can shape the final crown based on this digital data. And this is an advantage because otherwise you have to print the model and do the crown outside of this digital workflow with a much higher inaccuracy. So the accuracy of this procedure is 44 microns, which is completely feasible. So this is the advantage of the digital workflow completely. So this is what we aim to. This is a small parenthesis to the CAD/CAM technology and behind it. Now this is Azabine again. This is the situation of and shape of the abutments. And another feature of the let's say parameter which we need to respect software-wise, technician-wise, is the distance between the margins of the abutment, which has to be 3 to 4 millimeters in order to offer a base for the papilla to grow, respecting also the triangle between the crowns and so on. So this is Azamine. This is the case which we learned a lot about. So this is the abutments below it. After 2 years, this looks like this. Well, maybe it's not perfect, but those are parameters which we learn and you apply in a prospective studies too. So this is the situation before, and this is the situation after of this patient, which is nevertheless very pleasing and is a full success of the case, totally. Using also implants which are not losing bone and the bony and the soft tissue situation accordingly. So we see that the 4 millimeter parameters is worthwhile respecting because it's giving a stability of the construction. Now another parameter which is concerning the maintenance of the implant placement is not only the reconstruction of the bone, soft tissue parameter, design of the prosthetic abutments, of the prosthetic parts, but also the maintenance of these constructions, which has to be every 4 months a recall, because in the 4 months a mucositis can be predictably treated. But if we wait longer, can be a peri-implantitis, which we cannot solve predictably as we know today. That is why we do the 4 months recall and once a year a photodynamic therapy or a decontamination of the peri-implantary site and a digital occlusal adjustment in order to prevent bone loss and infection. And under those conditions, we give a long-term guarantee on our construction. So the sensor-based technology is really something worthwhile having, because it is solving you all the princesses on the P and the conventional prosthodontics, but also is giving you second-wise parameters to respect in full implant supported reconstructions, but also in the teeth and implant supported reconstructions concerning the implant time delay, which can be measured by seconds. So this is a very, very valuable technology, which can be looked after in this book, where in the chapter of digital occlusion and implant rehabilitation is described. So we use this digital occlusal adjustment in very many, actually in all steps of our reconstructions, at the beginning, in the provisional, in the final, and afterwards once a year. Okay. So this is also a subject of a multi-study center, which we will talk about in the next consensus conference of the Digital Dentistry Society, and you will know more there. Now, in the last couple of minutes, I will show you some of the cases which are also in the included in that prospective study, but made with other kind of technologies, other kind of guides. For example, this sleeveless guided surgery. So this technology is an innovation coming from Belgium, which is offering a sleeveless guide. The guiding is made by a handpiece, and by guiding the handpiece and not the implant or the drill itself. So it has a lot of advantages, independent of the things that the studies are showing a higher accuracy of the results. By now, more studies are needed. And it has also the advantages concerning the irrigation, the sterilization, the open kind of surgery, which offers you the possibility to graft also in the same session. For example, this lady, well, the parameters of planning is of course the same. So we respect all the aesthetic parameters of aesthetic planning, digital aesthetic planning. And we go for the surgery. When you don't have the closed procedure and you need to implement the bony or the soft tissue situation, of course, you use in full arch reconstructions methods which we know today that are implementing the soft tissue quality, which is matrices or even PRF. And this is a study which is now submitted and by approval at the Frankfurt University, with many matrices, a couple of matrices and PRF, to evaluate the result of the soft tissue thickness that we can gain and quantify it, because we know that the tissue thickness is really needed, and we have an evaluation of all these matrices, just less the parent teeth. So using those kind of methods, you can reach the tissue thickness and the tissue height, which is necessary to have and to protect our bone underneath. And we can go for the final restoration. As you can see here, this patient is then restored, and she's really very, very happy of her new situation. You can see that people here really like white teeth. I don't know, this is a trend. It will be maybe different in the future, but this is what we need. Now, dynamic navigation is another navigation technology which doesn't use guides. So that means you don't need that delayed time at the beginning. You can plan and go for the surgery immediately. The technology is working in a way that you need a target. You have to follow a three-dimensional target with your drill in order to place the implant in the planned position. So this method, needs skills and a learning curve. I agree with that, but it has a couple of advantages. So for sure, the planning is working the same as you know. So we can plan the implants the same way. When we have full arch reconstructions, we need a reference, a mini implant as a reference to place the to make it as simultaneization with the camera, or a reference for the camera. You can do all the procedures on an open situation, like with a free hand, but it has the advantage that is much more precise than the free hand. Now, okay, so This is the final situation. Okay. We have the advantage that we can evaluate with this technology immediately the accuracy. We have studies which show a better accuracy than the freehand placement, but still not as precise as the static ones. Yeah, and you have an open surgical area. So nevertheless, the static and dynamic navigation both needs surgeon's experience, and it's increasing with the surgeon's experience. That is why with all the studies which we do, we would like to shorten the learning curve and shortening the time of implementation of the digital workflow. Now, with all these navigation technologies and immediate loading procedure, over 3 years, we have a high success of the procedure and of the results. And as preliminary aesthetic parameters, I can share with you followings. We still need tests and studies about accuracy, trueness, and precision of different devices, and the accuracy of matching between different technologies. That's why technologies more in the same device would be very, very useful. We have the algorithms which are established, like tissue height, tissue thickness, and the algorithms according of a 4 millimeter added value, bone thickness, soft tissue thickness, bone height, and soft tissue height. Then minimally invasive surgical techniques like envelope technique, vista technique, smart technique for bone and soft tissue, or also incision techniques which are not leaving scars. So it's a paradigm changing also in the surgical field. We need an S-shaped emergence prosthetic design where the technologies are helping us to find the Z, find the thickness of the tissue, and to trace the margin of the abutment. We need 3 to 4 millimeters between the abutments as distance, and we need a philosophy and parameters also for the maintenance of the constructions which we establish. So those are a couple of parameters which we can put there and respect in the digital workflow of the full arch reconstructions, but it's more to come. Now, of course, the digital workflow is enriched day by day, and artificial intelligence and machine learning are the mechanism behind it. And it's there are a lot of platforms where this technology is active, beginning with 3D and 4D bioprinting, but also ceramic printing and so on. So we are really eager to go out together with the digital society, to go out, find the newest technologies, validate them through studies, and implement it in our daily workflow in a predictable way, and in a way that gives the patient, on a most minimally invasive way, the best aesthetic result that we can account. So if you need or want to know more and read more, you can register as a free member in the Digital Society. And I know that we have cooperation with the AIM Academy too. So feel free to come into the both families and take advantage of the informations there, and also of the e-learning platform which we have, and the open access journal BMC. Also, we have a cooperation with the Frankfurt University on the Master of Aesthetic Dentistry program. So if you have interest on that, please be free and take the information from there. Now, in these terms, I would really want to say a big thank you for the AIM Academy. I hope that I was able to share some of the parameters which we were working on and using today. And I look forward to a good cooperation with the AIM Academy in the future. Thank you so much. So now I can see a plenty of hello and good evening. We don't see the slides, so hope that you saw it. And please leave your questions. Okay, so far I don't have very much questions here to... I have one. Usually in the extraction and immediate implant placement for maxillary anterior teeth, the residual labial bone is very thin. Yeah, definitely. So that is why the extraction or the placement of the implant, and you are right, no implant placement will save that tooth and we save that buccal plate. That is why we have to increase, and this is a subject of many studies, to increase the soft tissue thickness and to augment the bone. The placement of the implant is much more palatal. You graft the gap every time, even if I didn't show it because it was not the topic, and you graft the soft tissue to a thick tissue biotype, because we know that if that two dimensions will be rehabilitated, we have 0.3, 0.2 volume loss after 1 year of immediate implant placement, instead of over 1 millimeter if we have a thin tissue biotype and thin bone. So that is the question. That is the answer to that. Okay, thank you so much. Thank you so much, everybody, by joining, and hope to see you in the future too, and join us, AIM and also the Digital Society. Thank you so much.